Ladies and gentlemen, thank you very much for logging in and attending this very interesting webinar. My name is Roberto Dina. I'm consultant pathologist here at NRL and the Cleveland Clinic, Abu Dhabi, and senior lecturer at Imperial College London. It's my honor and privilege to introduce my two distinct colleagues and brilliant pathologist, Dr. Asif Quadri and Dr. Haytham Dimashkieh. They both qualified abroad. Dr. Asif qualified in the UK, as I did, and Dr. Haytham qualified in the US. He's also a member of the fellow of the College of American Pathologists. They both share a common interest and deep interest in breast pathology. They are both lead pathologists in the breast cancer tumor board here at the Cleveland Clinic, and therefore they are always constantly in very strict contact with the clinicians. They are going to update us today on the breast biomarkers, and they're going to share the presentation. At the end of the presentations, I think Dr. Asif is going to start and then Dr. Haytham is going to carry on. At the end, we can have a brief questions and answer sessions, and I would invite anyone to write their question, their query on the chat box, and I will try to moderate that at the end. Without any further delay, I would invite Dr. Asif to start the webinar.
Thank you, Dr. Roberto, for this kind introduction. And I thank NRL and the breast reporting team for inviting me to talk in this very sort of memorable month. We've done this talk in recognition actually to all the patients who are fighting breast cancer, and also in recognition of all workers and healthcare workers who deal with and treat and help, and of course lab workers. And this will emphasize this presentation how lab staff are such core and vital to in breast cancer patient management pathway. Me and my colleague, Dr. Haytham, are going to share our experiences from this and share some update, and also bring to you the questions and the day-to-day runnings from the tumor board, which we are faced with. And I'm also very grateful to the marketing team who has done a fantastic job in starting all this up and finishing it and giving it the nice touches. So without no further ado, we're going to move on. So, okay. So the overview, part one will be my responsibilities. The overview will be a brief introduction. I will go very quickly over the NCCN guidelines in breast cancer. And my duty today is to talk about ER/PR and the new category of low ER positive. The second part will be what Dr. Haytham will be talking about the HER2 IHC update and the Ki-67 and the summaries. Okay. So if we look at breast cancer in figures, this slide is from the Global Cancer. This is from 2020 data. As you see, breast cancer supersedes on the right-hand side. If you see here, it's over 2 million patients a year and has gone above and beyond lung cancer cases. This is for both sexes and all ages. And you can see the incidence also here per 100,000, how it is also the highest. Pie chart shows us number of new cases in both sexes in all ages. You can see breast was highest, while number of deaths last year, breast is also among the leading causes, but not the best because of not the highest because of the advances in treatment and the screening programs and so on, and detection methods. In UAE, this was no different, the same trend. This is from last year from Global Can study. In a small population, relatively speaking, you can see still it was 21% of the cancers in this country. in UAE last year. Okay, so briefly, I'm going to pass on to the NCCN guidelines and why I want to share that. I always tell, I hope there are trainees and residents and uh, juniors here on the talk with us here online, is that we need to know the treatment of the disease we're diagnosing, because that is the key of to know what is the implication of the decisions we make, the black and white report we release, and what does it mean in the end, and so on. So knowing the disease we diagnose is half the game, I would say. So if you see here on the workup on this column on the left hand side, the workup from the word go after the mammogram and MRIs, depending on what it is, we have a pathology review and ERPR HER2. And second slide is showing you how the NCCN guideline, the decision tree, is very early on branched, depending on the ERPR and HER2 status of the patient. So the message is quite clear to us. Doing ERPR HER2 immunochemistry or testing is a standard of care which every cancer patient deserves. And other fact is that ERPR HER2 are a branching, very early branching point and decision making, and people who are ER negative, patients who are ER negative or ER positive will from very on will be on different dichotomy pathways. So ERPR IHC biomarkers, because our daily bread and butter work of immunochemistry when dealing with a breast biopsy is doing immunochemistry and immediately diagnosing a cancer and immediately requesting ERPR, because that's the standard of care. So the ask and the demand is that the first report already has ERPR HER2 status of the patient. Okay, so what is ER immunochemistry, ER, estrogen receptor, ER immunochemistry in a breast pathology? What value does it have? It carries a value of diagnostic. Very roughly speaking, breast tumors and uterine tumors can be ER. It's not exclusive in its diagnostic ability to tell us the tumor can be as a breast origin, but the prognostic value is what it comes with. ER positive tumors have better outcome. They are a surrogate for the molecular. In the 90s, work was done in Belgium where molecularly the tumor breast cancers by gene profiling were divided into luminal A and B, if you see on the right hand side in this box, and HER2 enriched and basal-like, and the concordance with the immunochemistry was above 75%, I would say, in the luminal A and B, slightly less in the HER2. So that surrogate determination is also very important to tally are the data between immunochemistry and gene profiling. And of course, it is ER and PR. Both of them are part of the algorithm of risk benefit of chemotherapy, and we'll come to that slightly briefly in the next few slides. And of course, the main important stay here will be the response to anti-estrogen therapy, tamoxifen. So that's the predictive value of ER. So it has three roles. So we're giving very essential information to the surgeon and to treating physician and oncologist when we are diagnosing breast cancer. Not only we're telling him that this is the cancer and what's the grade, but we've moved on to the next step and telling them what's the status and what treatment decision you can do and which pathway you will follow with your patient and what discussion the oncologist can have with his patient. Okay, so I want to just turn back a bit and talk about something on this seminal original paper and work done by the San Antonio group by Derek Allred. If you see the references here from 1999, where he looked at a population of breast cancer cases and examined and compared the ligand-based method, or old ligand complicated way of estimating ER receptor status and using immunochemistry and looking at survival rate and the benefit from disease-free survival probability benefit from tamoxifen. And if you see these numbers are the Allred score, 0 and 2, and he saw that after 2, which are ER negative in our calculations now, and after that the benefit raises, and you can see the disease-free survival, how the curve is plateauing as the ER score, not percentage, the ER Allred score goes up. So this is the original paper where behind that we have today's Allred score for ERPR reporting, and you can see this table is in today's College of American Pathologists guideline textbook in the guidelines already. Still, this table's there valid, and this is the basis of this, how this ERPR status and how the 2% cutoff was. The score 2 was, sorry, not percent, the score 2 was considered negative because that was the dividing line of survival and response to treatment to tamoxifen therapy. Okay, so the to reiterate the prognostic and predictive value of ER, you can see that ER positive will be less aggressive and they will be better responsive to hormonal therapy, and the recurrence score is low. It's low recurrence score will be less aggressive and so on. I'll leave the HER2 for my colleague. So this update, and if there are any juniors on the audience, I think this is a must-read article. This is the update from the College of American Pathologists and ASCO, the American Society of Clinical Oncology. And a lot of what I'm going to say is dependent on this update from last year. And this was published and it's open in the Path Lab, Archives Path Lab, and in JCO last year. Okay, so in a nutshell, this is from the paper where the updated recommendation is very clear that what is positive, 1 to 100% tumor cells when their nuclei are positive is considered positive, and reporting 1 to 10%, we should have the new category of low ER positive, and we have to mention low ER positive in that. And I'll come to these points in my next few slides. So this is the largest update between the 2010 and the 2020 recommendation from the ASCO CAP is the introduction of a category called low ER positive cancers. So what is low ER positive and why is it so important? Because so the data which we have previously is from research and trials done in the 90s. In 2011, there was a meta-analysis showing and looking at 500,000 woman years follow-up who had 5 years of tamoxifen therapy, and they compared ligand-based calculation of the ER, estimated the level, and the hormone response to tamoxifen therapy. And what they saw is that the change and benefit of therapy between 1%, less than 1%, 0 and less than 1, and the people who are 1 to 10% is not very much, while the actual benefit is very remarkable and noticeable when there are more than 10% that cells are immunoreactive. So this puts us in that category. Of course, this information now coming that and availability of new therapies has combined that we have to think how we can benefit more and pigeonhole our patients in different categories so they benefit. Because now this category, the importance of this, why we have that, they may benefit from hormonal therapy. So it's not a given. Because of the research I told you, it's a heterogeneous group, and the outcome will depend on the molecular profile and biology, and some of them will behave like ER negative cancers, and that's why we ER low positive patients, especially if they are PR negative and HER2 negative, are critical because they actually may benefit from triple negative breast cancer trial therapies. So, in a small study of patients, when they looked at them, the N is only 183 here. But if you see the low ERs, we're actually having a molecular profile of basal type tumors, and we know basal type tumors are aggressive tumors, and they can be triple negative also. Okay, so that's the importance why the low ER category should be reported separately. And so on. But what does that entail from us, our day-to-day work as technicians, lab directors, immunochemistry section, our bench work, and the breast pathologist and the breast MDT? How does that tally in and link in? We'll see that in a minute. So these are images from the paper showing you strong and moderate ER positivity, but it's these cases where you see it's very faint, and these are the cases where I say my Asif, we need to, I put a break on when I see a breast biopsy which looks negative or has a very vague brown nuclear staining, and these are the ones where you go look at them at low power and you decide are they the category which is between 1 and less than 10%. And then you go for low ER positivity. I usually show these cases to another colleague before I call that. Okay, so the lower A positive case, what's the college guidelines here? How do we deal with them? So sorry, the handwriting may not be written, but we'll tackle that in a minute. So after we've done that, there is adequate amount of tumor, the fixation's okay, and so on, and we see, and there's a low ER positive. So what this is the action which needs to be taken in the guideline, which is we have to have an SOP, and this is what is recommended to everybody. We need to go back to the drawing board and sit down and look at ER positive and ER negative rates and HER2 negative, and how we deal with the ER low positives and what should we do. So that's why in CAP requirement is that we have to give our ER and PR and HER2 figures and statistics every year. So look back exercises are so important. So even if the lab is not, your lab is not CAP accredited, it's very important we go and look at that, because if 79 and 84% of breast cancers are ER positive and only 1 and 2% of those cancers are low ER positive, we're talking a very small. So chances of detecting them will be only when we do look backs and look at this from a bird's eye view and take a step back and see, okay, let's look at our rates of low ERs. Okay, so what is the steps which the college and ASCO are asking us to do when we are dealing with a low ER? When we're dealing with a low ER case. So we should review our controls, our internal external controls. That's so important. And we get another colleague to look at it. We look at it again. And if we have image analysis systems, we go and use those also. And we have previous results, we go and compare them. And if not, it's not fitting, we retest if we have any doubts about the pre-analytic stuff and the variables. Or even go and test on a different block if we think the controls, internal controls, if there are no internal controls or the external controls are not working, or we're not sure about the pre-analytic, we repeat the test before calling something low ER or ER negative. So this is the SOP for that. Okay, so the college has put in this in publication template for biomarker. I would recommend everyone who has not seen this or not exposed to it or is not part of the CAP accreditation, go and read this document. It's a 4 or 5 page document. It's fantastic and it lays it out. And if you see, the disclaimer has telling you that if you have no internal controls, what you do, and when your tumor is negative and no internal controls and outside controls, you can say indeterminate, I'm going to repeat it, you cannot depend on it or cannot be reported, and so on. So every department has to have this disclaimer ready for its ERPR reports. So this is at NRL where we do this. This is our reporting system, our disclaimer we have, and this is the comment we're going to put, which is ditto from the college and ASCO recommendation. That if we have a cancer with low level, 1 to 10, what does that mean? They benefit or may not benefit, and they're heterogeneous and may not benefit of endocrine therapies. Okay, so why can we have, what are the reasons to have a false negative result? There could be ischemic time, fixation, heat exposure, decalcification used. Bowens can damage immunoreactivity, antigen retrieval, type of antibody, or overstaining also. The other practical point which I think I want to pass today on is that the morphology is so important, and you will see how this is linking to what's going to happen now. It's happening at research level. So when you, as a pathologist and even as a trainee, when you're looking at the morphology of breast cancer, immediately the grade of the tumor or the look of it should actually give you an anticipation. So it would be highly unusual for these tumors to be ER negative, which are low-grade tumors or purely lobulars or purely tubulars or purely mucinous or encapsulated capillaries. And highly unusual for these tumors to be ER positive, which are metaplastics or adenoid cystics or secretory. So this is very important, and the college and ASCO and CAP are emphasizing that this is important, the morphology, and this is where you're going to go and look back at your staining, and is anything wrong, and you can look back. And if you have an outside case, you go repeat that staining. So what about PR briefly? It has a predictive value, especially when ER is positive, PR negative can tell you the prognosis and benefit from treatment. Low PRs, poor prognosis. Of course, it is also part of the nomograms and McGee equations and IgC4. These are all risk-benefit modules for chemotherapy, just like Oncotype DX. Okay, so the recommendation is that we continue using it. There's no low category, and PR is optional for DCIS. You don't need to do it. We only do ER. Okay, so when would you repeat the specimen? When we think that the core was insufficient or equivocal or discordant results from the clinical or histological findings, as I said, and the grade in morphology, and you have specimen handling is questionable, and so on. So I just want to leave you with the final thoughts here for me as what is artificial intelligence and algorithms and the future entailing. Already this on the left hand side is not the future. This is image analysis, and it's available even on a clinical and a commercial level, where image analysis can calculate the ER or Ki-67 or PR percentage staining of nuclei by softwares. But this is something on the right hand side is telling you how deep learning systems can predict ER, PR, HER2 without staining on H&E features. So this paper is from last month in Medicine Communication from one of the Nature group. A very complicated paper, a lot of technical stuff in it, but I just want to alert everybody and also myself that I was just looking at it, how things are changing, where you can see H&E and IHC for ER, PR, HER2 was scored, and these areas were scanned, and these areas are called patches. So the patches were patch level results were done, and then the whole slide result for immunochemistry by using deep learning software. So they were scored, and then they were taught to the computer, and there were multi-layered systems were used, and where they were predicting the ER, PR, HER2 only by the morphology of cases. So the computational learning was put there by using data, very complex and huge amount of data to do that. So I mean, if we leave the technical things beside, which was over my head also, the technical, what the message I could understood in my modest opinion from this paper is the future is that already computers and softwares and algorithms can calculate some things for us. But on the right hand side, when you see the morphology, and we can teach computers from morphology to predict, they'll be good at clinical trial levels, where they can have treatment pipelines ready, and they want to see how large population or samples and cohorts can be tested. It can help us to choose which block which is tumor rich, and also help us which is most responsive. It also can help us into equivocal cases, but this is far from clinical benches or clinical labs. This is on research level only. So in summary, I wanted to reiterate that ER, PR, and HER2 are standard of care, and we have a huge role as lab physicians and lab personnel when we come to patient treatment, when it comes to breast cancer patient treatment. And you can see how the low ER category is a new category, and there's a set workflow to follow. An SOP to made. We need to go on the drawing board and go and discuss and with all the stakeholders, which will be our technical team, of course, and the pathologist and the breast cancer MDT, oncologist, and surgeons also. And actually, if you see, the recommendation is that these guidelines were not made only for us, they were made for the clinical team. So don't be surprised. The tumor board oncologist will discuss with you and ask you, did you think this was ER positive, low ER positive? Because he will have a specific discussion with his patient. Thank you very much. We'll move on to the second part of and I'm going to unshare my screen, and we'll move on to Dr. Haytham Dimashkieh, my esteemed colleague. Thank you. Haytham, to you.
Thank you, Dr. Asif, for such a wonderful and concise presentation. Let's reiterate the importance of HER2. So HER2 is a gene that is amplified, and this protein is overexpressed in approximately 15-20% of breast cancers. Why is that important? Because these cancers that overexpress HER2 can be treated with a target monoclonal antibody that can stick to the surface of these cells. So Herceptin was the first drug that was first approved to treat HER2 positive breast cancers. However, since that time, the treatment of HER2-positive breast cancers has evolved, and now HER2 positivity and HER2 status is important in the treatment modalities of many different types of breast cancer. So the role of HER2 is changing in the treatment of breast cancer, or when it can be used. So recognizing the importance of HER2 status in breast cancer, in 2007, there was this first joint ASCO and CAP meeting where they put down standardized guidelines for the testing and reporting of HER2 status. So at that time, there was a concern that they didn't want any high false positive rates. So they put the cutoff to calling a HER2 stain positive at 30% of the tumor cells. And at that time, the in situ hybridization equivocal ratio was based between 1.8 to 2.2. This was further revised in 2013, and at this time they were concerned for the false negative rate, so they dropped the IHC 3+ or IHC positive result for HER2 down to 10% of the tumor cells. At the same time, they created new in situ hybridization positive groups. They talked about in situ hybridization equivocal groups. They clarified the concept of heterogeneity, and they also put recommendations for retesting, and they recognized that sometimes there are discordant results. Now in 2018, they took the 2013 guidelines and refined them, and they refined some fine-tuned definitions and result reporting. Now there's no more in situ hybridization equivocal results, and all this in the hope to better identify who will most benefit from treatment. So for the purpose of this presentation, I'll be focusing mainly on the 2018 ASCO and CAP HER2 guidelines, and specifically address the 2 of the 5 questions that the article or the guideline emphasized on. So these will be clinical question number 1 and number 2, which pertain to immunohistochemistry of HER2. I will not address questions 3, 4, and 5 since they pertain to in situ hybridization, which we don't currently do in our lab. So what are the 2 clinical questions that we'll be talking about? So quick clinical question number 1 is, what is the most appropriate definition of IHC 2+? And clinical question 2 is, must HER2 testing be repeated on surgical specimens if initially negative on the core biopsy? So what were the changes that happened between 2013 and 2018 with regard to these 2 clinical questions? Well, for clinical question number 1, HER2 IHC equivocal was redefined as weak to moderate complete membrane staining observed in greater than 10% of the tumor cells. With regard to the second question, there's a change in 1 word in the repeat testing of HER2 if the initial HER2 was negative and now you have a resection specimen. It was changed from must to may. And we'll talk about this in more detail in the coming few slides. So let's first delve into clinical question number 1. So in the 2018 guidelines, the new definition of equivocal IHC 2+ HER2 is its weak to moderate complete membrane staining observed in greater than 10% of the tumor cells. So why did this come to be? So if you recall, in the 2013 ASCO guidelines, the definition of HER2+ was that it should be incomplete and or weak to moderate and within 10% of the invasive tumor cells, or complete and circumferential membrane staining that is intense in less than 10% of the tumor cells. Well, after that guideline was put, there was a lot of feedback from pathologists to say that this is very confusing and contradictory, and there was a tendency for many pathologists to upgrade to 2+ or down or undercall 1+ and send for reflex testing. The other fine-tuning that the 2018 guideline did with regard to the equivocal IHC 2+ HER2 result is that there's some unusual scenarios when you do HER2 testing that should be considered also 2+ equivocal. These are unusual staining patterns, and if there's strong circumferential membrane staining in less than 10% of the tumor cells. So clinical question number 1. So this, so back to clinical question number 1. So this diagram here or algorithm is taken from the 2018 article, and it shows the algorithm on how to evaluate HER2 IHC testing. What I want to point out first is that when it comes to HER2 3+, there's an asterisk here. So this intense staining should be seen at low powers. So So the refinement in the IHC 2+ is that now they're making it clearer for us to distinguish between 2+ and 1+ and 2+ and 3+. So in a practical way, so if you're faced with let's say you're looking at a HER2 IHC slide of an invasive breast cancer, there are two things that you should be looking for. One is the completeness of the membrane staining, and two, the intensity. So if you have incomplete membrane staining, then most probably you're dealing with a 1+ tumor. If you have complete membrane staining, then the next important thing is to look at the intensity of the staining. So if it's a strong, bold, membranous staining, then you're more likely dealing with a 3+. If it's a complete, membranous, wispy, or thin staining, then you're more likely dealing with a 2+. And again, this is all present in the 2018 article under the footnotes of this algorithm. So what are the other patterns that should be considered as 2+? As we said, the 2018 guideline recognized there are some unusual staining patterns that also should be considered in 2+. And again, these are present as a note in the footnote of this diagram. So what are these unusual patterns? So one pattern to consider is the basolateral staining only pattern, and this is typically seen in micropapillary carcinomas. And these tumors tend to be HER2 amplified if HER2 FISH is done. So that's one pattern to keep in mind to call 2+. Other patterns, if you have a granular staining pattern of the cytoplasm, to consider 2+, or if you have only basal staining pattern, to consider 2+, and send for HER2 FISH. The other unusual staining pattern pertains to if you have a very focal area of intense membranous staining. That means you have a very focal area that looks like 3+. However, it consists of less than 10% of the total tumor surface area. So in these cases, there are two options. So one could either send the tissue out for HER2 FISH and they'll be treated accordingly, or you can go back and stain other tumor sections with HER2, whether from the primary tumor or if you have a metastatic site like a lymph node, and see if the percentage of the tumor will increase to more than 10%. Pertaining to clinical question number 2, the issue of repeating HER2 testing if the initial core biopsy is negative. So in the 2018 guidelines, the word that was changed was from must to may. So in the 2018 guidelines, it reads if the initial HER2 test in the needle biopsy is negative, then a new HER2 test may be ordered on the excision specimen. The reason of this change is that because of the high concordance between of HER2 status between the biopsy and the excision. So it was rendered up to the discretion and the judgment of the pathologist to see if they needed to repeat the HER2 testing on the excision. However, the 2018 guidelines did give some guidance to when this scenario may happen. For example, if you're dealing with a high-grade tumor and the initial biopsy was negative, if the amount of invasive tumor on the core biopsy is small, if the resection specimen has high-grade carcinoma or areas that are different from the core biopsy, if on the core biopsy, both by IHC and ISH, the HER2 results is equivocal, or if there's any doubt regarding the pre-analytical variables in the preparation of the core biopsy. So this is the case where we don't want to miss a false negative. And this is also in the same theme, again, in this diagram as a footnote, it is said that when we analyze HER2 IHC, it's important that the final report results assume that there's no apparent histopathologic discordance. So the 2018 guidelines also wanted us to make sure that we don't miss any don't have any false positives. And these primarily pertain to those low-grade or more well-differentiated tumors. So, for example, the 2018 guideline states that a new HER2 test should not be ordered if you're dealing with a well-differentiated tumor as these, but a new HER2 test should be ordered if the initial biopsy HER2 was positive and you're dealing with a well-differentiated tumor. So along those lines, it's important to keep note that mucinous carcinoma is one of these or mucin-producing carcinoma is one of these tumors that can mislead us. So a pure mucinous carcinoma is usually pure in the sense at least 90% of the tumor is mucinous, is ER positive and not high grade. And that's why it gives it its good prognosis. However, a mucinous carcinoma should not be HER2 positive, it should not be ER negative, and should not high grade. The most important thing is that a mucinous carcinoma per se should not be classified on a core biopsy. So if you're faced with a carcinoma that has mucin pools, don't jump to the conclusion that this is a mucin carcinoma, as it could be a tumor that's producing mucin and then maybe a high-grade tumor. And this is an example where if you're faced with a mucin-producing tumor, and even though it looks like a colloid carcinoma, low power, and it stains for HER2 positive, this does not mean this is a mucinous carcinoma. It's most probably a higher-grade tumor that is focally producing mucin. So this leads us why it's important to have the correct interpretation of predictive markers. So recognizing how important HER2 status is from a clinical perspective and the treatment of patients, making sure that we follow the most updated guidelines to make sure that we have all the pre-analytical, analytical, post-analytical variables in check so that we can reproduce a consistent, high accurate result. And as a pathologist, always to put the HER2 results in context and correlate with the histology and beware of any discordance or unusual results. I'll go on to further talk about Ki-67 briefly. So Ki-67, another breast biomarker that is used, is a nuclear protein. It's a good reflection of the proliferation rate of tumors. In short, if a tumor has a high proliferation rate, it has a worse overall prognosis, but at the same time, it shows a better response to cytotoxic chemotherapy. However, Ki-67 has faced challenges over the years, and this is because there's a lack of consensus on how to score Ki-67. There's no clear-cut definition what represents low expression versus high expression. Many times there's no cutoff point in Ki-67 to consider that a positive test. The other problem is, where do you score the tumor? Tumors may be heterogeneous in their Ki-67 proliferation. Do you score the leading edge, hotspots? And overall, there's still a lot of paucity of data regarding the effects of pre-analytical variables. So for all these reasons, routine testing for breast cancer for Ki-67 is still currently not recommended by both ASCO and the NCCN. However, as clinical trials continue and our understanding of breast cancer and breast cancer treatment changes, there may be a role for Ki-67 in the future. In December 2020, there's an international Ki-67 breast cancer working group that set around to study Ki-67 breast cancers, but up to date, the only clinical utility that was found was limited to Ki-67 being a prognostic marker in early an early ER positive disease that should receive adjuvant chemotherapy. So in summary, the 2018 guidelines redefined what is IHC 2+ equivocal and made it clearer for practicing pathologists to distinguish between 1+ and 2+ and 2+ and 3+. More importantly, pathologists must tune themselves about the likely biomarker status of a tumor when they're evaluating histology. So as Dr. Asif had said earlier regarding ER, the same applies to HER2. So if you're faced with a low-grade looking tumor and HER2 is positive, so this is either a false positive result, or maybe you're dealing with a more aggressive tumor that is not totally represented. And as Dr. Asif mentioned earlier, not only pathologists now are involved in understanding the HER2 status, our clinical colleagues may discuss these and even challenge us when a HER2 status may be discrepant or discordant. And more importantly, laboratories must have a robust quality assurance mechanism and use standard operating procedures to stay updated with the new guidelines. So in summary, accurate HER2 evaluation is a key in treating of breast cancer. So as we end this presentation, I just want to go briefly and show you how the breast cancer reporting has evolved over the year. So in the 80s and 90s, we're more focused on the pure histology, what the grade is, what the tumor type is. In the 2000s, we entered the age of the biomarkers. And now, as we move forward, the ancillary component of the breast reporting is getting more and more important, and likely the next phase would be molecular testing on breast cancer. So with this, I would like to acknowledge the breast pathology team at the National Reference Laboratory Clinic Abu Dhabi, Dr. Basil Trabulsi, Dr. Suhail Al-Amiri, Dr. Asif, and myself, and also the Anatomic Pathology Laboratory and Immunohistochemical section, because they are key and vital in the production of the tissue that we evaluate, and the high quality that they allow us to allow us to interpret these results accurately. So this ends the presentation. I'll ask Dr. Asif if he has any other final comments to share with us.
No, thank you very much, Dr. Haytham. Fantastic talk about part 2 and KI67, and I echo our acknowledgement to our colleagues, and also our technical staff and the engine room, and we want to thank again the marketing team to make this webinar available and open and accessible to many people. To you, Dr. Roberto, thank you.
Thank you very much to both of you for a very exhaustive presentation on the biomarkers of relevance in breast cancer.